on where we're winning, and I'm happy to take a crack at where we're winning. I'm going to be smart enough to defer on the ACL injuries because I've got three people here who know way more about ACL injuries and ACL management than me, which is appropriate and great. So I'll just start, I'll take my crack at it and then pass on the baton. That I reckon we're winning on education. So if I think back, there was this idea of what, as a doctor, when I was seeing patients, what would you inject, right? It was like, what's the magic thing? And it doesn't matter that their loading is ridiculous and that their biomechanics are ridiculous, and but it's just I'm going to inject something and fix them. And I think what I'd say is clearly different now is it's a shared decision-making model, and the players are more educated, and we're discussing these things, and there aren't always grey. Brookie's looking really worried. It's worrying me.
Just interested.
So it's this idea that. There's much more knowledge. So then if we just go with ACL, that discussion of cross-bracing versus the rehab without necessarily cross-bracing versus you need surgery. So I think that the players are more engaged and more knowledgeable. The clinicians have got a much higher knowledge of evidence to start off with. And so they're much more sophisticated conversations is where I'd probably start on what we're winning with making the point about communication, education and realising, and humility, I'd say, is that, and empowerment, the patient has to do their role and it's not someone externally fixing them. So they're all issues that you've thought about and you've got material on Learn.Physio. If I just go with one other one, I'd say that with tendinopathies, it's this load management as a core business. And so we're in the tendinopathy chapter in this book of managing injuries on the Achilles tendon. It's like Robert Johan de Vos is making the point, look, there are three parts. And education is one of those parts. Athlete education is one of those parts, whereas that wasn't something we talked about before. And in the book one, we talk about athlete education as a chapter. It's the first time I've had a chapter, and it's like athlete education, how to do it. So I'll stop there and head it back to you.
Do you want to make a comment on
the ACLs? I mean, we can change a lot of things. We can't change biology, and there's healing times, and we've tried. I mean, we've made lots of attempts. The profession's made lots of attempts over the last 30 years to accelerate the whole. From artificial ligaments to stem cells to whatever. But nothing has really made a difference because you can't change biology, and so it is a bit frustrating that it's still takes 12 months to get back in, and everyone's looking for that magic bullet. But no, I don't think ultimately you can change biology. We can get better at their performance when they get back. The thing now is that I think most high level or medium to high level athletes get back from an ACL reconstruction to their previous level, which certainly didn't happen back in the day. So I think we're much more efficient at that, but maybe the time frame is not. We haven't actually reduced the time frame, but I think we're much better prepared when we go back than we used to be. But we'll keep trying to reduce that time. But I just don't think you can change biology that much. I mean, people are making attempts to change biology, but I don't think that's been successful so far. So, there are limitations in what we can do, certainly. I think the prevention thing is really interesting. I think, there is evidence now that we can, there are good prevention programs for things like ACL. The frustrating thing is that they're not embraced by the sporting teams and by the individuals.
Did you guys discuss that and talk about that for these latest editions of the book? And that is that prevention is better than the cure. We know that, but particularly with sports injuries, I mean, you've got a big platform. You can get that message out there. How did you integrate that into the latest editions?
Yeah, so it's one of the principles and foundations of our work, and so it's in the book Foundations, which is available now, the first book, in the student book. So Carol Emery's a new editor in the Prevention in chapter, building on Roald Barr, who's still in that. So we feel we have a fantastic chapter, and then there are these concrete examples like Prep to Play, to use a local example, and other prevention models that have been shown to work with QR codes, and people can go. There's actually a very substantial list of those. So we try to give the principles from the leaders, and then we've gone to the QR codes to help people move to other additional resources.
Awesome. That's a great translation. Looking at something probably a little bit more complex and complicated, like low back pain, for example, and probably just taking a little bit of a sidestep to something a bit more challenging. Like how's I guess from a perspective of now back back, once again, 30 years ago, low back pain was probably either seen as acute or chronic. Now the language we use, pain education, manual therapy versus hands-on versus hands-off, passive modalities like electrotherapy and dry needling and taping, all this kind of thing. How have you navigated that kind of back pain in particular, like being such almost like a polarizing topic? We sometimes are a bit scared on Learn.Physio to put anything out there for low back pain because we just know there's going to be comments are going to be full of opposing views and very strong views sometimes. If we put something out there it's a little bit controversial. Like, how have you guys sort of buffered that and changed over time according to the evidence? Like, I think that's one of the trickier things we come across as Learn.
Yeah, obviously the early editions were very sort of mechanical. We'd be using electrotherapy, we'd be using manual therapy. Probably wasn't as much emphasis on exercise as there is now, and then certainly nothing on the sort of the biopsychosocial sort of side of chronic pain and so on. So what we tried to do in this latest edition, which we have Peter O'Sullivan contributing and a bunch of experts in low back pain, is sort of balance between the biopsychosocial, which is probably more of a factor in chronic, longer standing low back pain, compared to the more sort of acute low back pain that athletes would get. So we've sort of tried to demarcate between the two, and because they are I believe very different.
You'd have your acute low back pain and cricket fast bowler, for example, or a
so
rower
you've got
or
your
something.
specific, ones like a stress fracture, past stress fracture in the cricket fast bowlers and so on. But we've had Larry Treese, Dr. Larry Treese from the AIS, who's done and Kelly Wilkie, who've done a lot of work in rowing, and she's actually just finishing her PhD on acute low back pain. So she's done the section on acute low back pain in the athlete, and then we've also got quite a lot on the sort of the more chronic, longer term low back pain and the combination of both.
How did you write that in the book, by the way? Did you just split it into acute and chronic and have Pete kind of do the chronic bit?
Yeah, sort of. Yeah,
right.
I mean, we've tried to balance it all and so on. Obviously, Pete wrote, all his group sort of wrote very much, the more chronic one, but we realised, there's this whole group of athletes that aren't chronic low back pain. So we've got a box or a couple of pages of in that chapter of looking specifically at the athlete with the approach to the athlete with low back pain and talk about the sort of shorter term issues and so on. And Larry's done a great job of that. So it's always a balance. I mean, obviously, people have a focus and so on. So it's our role really is to sort of take the overview and get a balance between the different approaches. Whether that be surgical versus rehab, whether it be biopsychosocial compared to manual therapy, and so on. So, and we don't, maybe we don't always get the balance right, but it's providing those different alternatives, those different options, and so on.
Is there in 2026? Is there still a role for manual therapy, electrotherapy, dry needling, stretching, mobilisation?
I believe there
backs?
is. Yeah, I'm not sure about electrotherapy. I mean, it's probably not as much of a role, but I certainly believe that there is still a role for manual therapy. There is still a role for dry needling. I'm a big fan of dry needling. But I think we will also have to be cognizant of the chronic pain and those sort of other issues. So it's a balance. I mean, I'd like to think we're not just one way or the other. They all have a role to play, and I think the best treatment is to have a combination of all those things, and that's what we try and present rather than just going down one track and so on. It's tricky in the balance because everyone has their own, as you said. You'll get lots of comments and so on. Everyone has their own bias, and I have a bias towards dry needling because I find it very effective in my practice, But other people say, oh no, I don't use it. So you've got to sort of try and Peter O'Sullivan might have his bias and so on. So it's a balance, and obviously we take into effect. Clinical experience, both our own clinical experience, but also the clinical experience of experts, and then the evidence. And so we're we try and get a balance between them all. You know, there's expert opinion, and nowadays, you know, in the academic world, that seems to be poo-pooed a little bit. It's all evidence-based medicine, but I believe expert opinion and experienced clinicians is incredibly important. You know, just as important as the evidence and so on. So we try and marry the two.
Yeah.
Yes,